I'm Alden Harken. I'm professor and chair of the Department of Surgery at University of California, San Francisco, East Bay. And I'm also chief of surgery at the Alameda Health Systems, which is where we are right now. Early on, when I was, 8 or 10 years old, my grandfather, who lived in southwestern Iowa, had been a graduated from high school in southwestern Iowa. After high school, he sold Encyclopedia Britannicas for a year and a half, decided, that's not what I want to do. He thought, I guess I'd really like to be a doctor. So he went up to Des Moines, took the Iowa State medical examination, passed it, and practiced really general surgery, psychiatry, burns, family practice, OB, for 55 years in southwestern Iowa, never having gone to college or medical school. And patients seemed to relate to him very effectively. He had a remarkable opportunity over the 55 years of getting to know 3 and 4 generations of patients. And as far as I could tell, he never kept any medical records at all. It was all in his head, but he knew the patients and the families so much better than they did. That he could, I remember going and making some house calls with him. We'd go up and he would tell me before we got there what the patient was going to complain of, what the wife was going to say that was really wrong with him, and they would banter back and forth, and it was as if he'd written the script. He knew them so well that and they were always tremendously grateful, and I would watch him treat what I thought was a similar problem differently depending on who the patient was. You go to somebody's house and discover that their shortness of breath is caused more by the fact that they can't get heating in their apartment, or they just turn the gas off, or their anxiety has nothing to do with some kind of global depression. It's the fact that they think they're about to get evicted. Those are major problems, and if you can help them deal with that, it seems to work out better.
It's not common for surgeons to make home visits, and it seems to have become a core piece of what you have chosen to do. And can you explain why that's important to you?
I always thought that any kind of physician who incorporates the rest of the patient's life into their therapy seems to have a much better relationship with those patients, which is the kind of fun of medicine, but also it seems to get better results. Now, maybe that's just my bias, but it's a pretty firmly held bias.
I'd like you to describe a patient that you saw in the home and what that taught you.
Early on, when I was back in Philadelphia, I had a patient that had a laryngeal carcinoma. And I was called as a surgeon to see this patient because she was having progressive difficulty breathing, getting air down into her lungs. And trouble breathing is a bad problem, and that's not a fun way to have trouble. And so I was asked to place a tracheostomy in her, which I did, and she could breathe much more comfortably. But I was also asked to place a feeding gastrostomy into her. And she seemed to have the indication for that. She couldn't swallow her saliva, she couldn't swallow her food, she was losing weight, and so the indication was clearly there. I put the tracheostomy and the gastrostomy in her, and then I dropped by her home just to see that she was doing okay. And I remember being startled. She was a very bright lady. She had an architect's son. They were capable of blenderizing her food, feeding her. And I remember thinking after several visits how uncomfortable she was. She was basically in solitary confinement. She was so worried about the smell in the apartment, the fact that she couldn't deal with her saliva, the fact that she had a trash can in the center of her living room that she'd fill it up with Kleenex just from her saliva every day, so which made her embarrassed to invite her friends over, so she was living alone. And it occurred to me that with the tracheostomy, I'd made it easier for her to breathe, but with the gastrostomy, I had prolonged misery for, must have been 6 months. And I talked to her very thoughtful architect's son and her about what the quality of her life was, and it was bad. And I thought that the indication for a procedure or a medication needs to be placed in perspective of what the patient's doing and how they're living and what the impact of that therapy is going to be.
How did that experience influence kind of how you think about how you provide care and how you teach your own students?
We try and make the case that it's important to get to know the patient and what the impact of your therapy is going to be. And so just the fact that the textbook says you've got an indication for something doesn't mean you should do it. And now whether they just do better because my relationship with them is better, I don't know, but I guess I don't even care. The biology is, it's the perception of the patient, and if the patient thinks they're doing better, they usually are. And my goal is to make them comfortable and happy with their existence. And again, if they understand what the therapy is, and it doesn't have to be exclusively pharmacologic or surgical, it can be your interaction with them, you're trying to help them relate to a disease. If I or other physicians, I think it makes sense to start as medical students. You don't have to be an accomplished physician to go out and meet people where they live and see what they think and get a sense for both the rewards of where they're living, but also the hurdles they're overcoming. And in many instances, there are real problems associated with just living in some parts of this country. The anxiety associated with living in a dangerous neighborhood, and there are many dangerous neighborhoods, lots of places that are walking distance from where I am right now, that patients say that they go home and by 4 o'clock in the afternoon, they get inside their house and they won't go outside. And getting a sense of what that is as a physician, I don't even think it has to be a physician, but as a physician, it's much easier because your access to patients' homes, lives, thoughts are special. And as soon as you can earn their trust, all of a sudden their lives open up and an opportunity to impact doesn't have to be exclusively medical. And if that opportunity occurs, I would argue that it's equally gratifying, rewarding, and fun. So I would encourage everybody to do it.